Hello students, today we will be studying one more important topics from neurology, that is myasthenia gravis, along with the differential diagnosis Lambert-Eaton syndrome. So what is the definition of myasthenia gravis? It is a chronic autoimmune neuromuscular disorder characterized by muscular weakness without atrophy. There is no muscle atrophy. Okay, muscle size will not be reduced, but there will be muscular weakness. Or one more definition is autoimmune neuromuscular disease characterized by generalized muscle weakness due to antibodies against postsynaptic acetylcholine receptor. So what is autoimmune disease? Where the body will produce the antibodies against its own cells or tissues. Here in the myasthenia gravis, it is produced against the receptor which will accept or which will be used during in the acetylcholine impulse transfer. Okay, the antibodies are produced against this postsynaptic acetylcholine receptor. That will, so what will happen? There will be no impulse transfer. The muscle will not recover. Muscle will not have any impulses through these synapses. So if we see here, in a normal person, this is the nerve, this is the muscle, and this is the acetylcholine receptor. This is the acetylcholine. So what happens through the synapse? This is the synapse. Through the synapse, the acetylcholine will be released from the nerve, and the acetylcholine will transfer to the muscle area, and along with this impulse will transfer. That is in the normal person body. So what happens if the patient is having the myasthenia gravis? The nerve will produce the acetylcholine, or acetylcholine will be there in the synapses. Here the antibodies will be produced against these receptors. So the receptor will combine with these antibodies. It may get destroyed, or it will just combine with these antibodies, and the neurotransmitter will not bind with this receptor. This neurotransmitter or acetylcholine here will not bind with this uh, receptor, and the impulse will not be transferred to the muscle. So muscle contraction doesn't occur here properly. That is about the condition. So what are the reason? The major reason is only one: autoimmune disorder. Some of the autoimmune disorder are rheumatoid arthritis, sarcoidosis, systemic lupus erythematosus, or Hashimoto thyroiditis. These are the major etiological factor or causes for this autoimmune disorder. If these are all present in a patient, okay, these four conditions are present in the patient, then you should test for myasthenia gravis. There could be a chance for the patient to get this myasthenia gravis. And there could be one more, that is thymic hyperplasia. The second cause, thymic hyperplasia. So thymus gland present in the child due in the chest region. Okay, you can see here in the chest region it is present, but after the once the person become adult or adolescent, this thymus gland will degenerate, and it will not produce any antibodies or any secretions. But if the condition like thymic hyperplasia is present, that could be because of the presence of benign tumor in the thymus gland, or the enlargement of thymus gland happens. What happens? It will produce the antibodies against thymoma, and the same antibodies will next bind to the synaptic receptor, that is a neurotransmitter receptor, and it will, after binding, what will happen? The synapse will not produce any impulses which will helpful in the contraction of the muscle. That is the one more etiology. So what are the types? The types are ocular myasthenia gravis, it will affect only the eyes. And one more is neonatal transient myasthenia. This is the one more type. Here IgG antibody enters the baby's body from pregnant mother. You know that these chemicals or the any diseases, some of the diseases are transmitted from the mother to the baby. So in this case, the IgG antibody from the mother will enter into the baby's body. So what will be seen? There will be a floppy baby. Okay, floppy baby. It is like no muscle tone, and baby will be like no much activity through the muscles. There could be a risk of aspiration because the muscle which control or blocks the windpipe when you are having food will not relax properly or will not contract properly, so there could be a risk of aspiration because of the muscle weakness. But after some month, this baby's immune will be produced, or immunity gets stronger, and it will destroy these antibodies. If we, after the test or some of the condition, if we see, if we find out that there is this antibody which are transmitted from mother to baby, then we can give the treatment called as neostigmine drops. This can be given to the baby. Which are the clinical symptoms or the clinical feature or signs or symptom, also called as, can be present in this myasthenia gravis? Usually the symptoms worsens with increased activity, and it will improve with the rest. When you're doing activity, it will increase, but if you are in your rest, then it will reduce. uh, First, only the smaller muscles will get affected. So here you can have a diplopia, that's a double vision. There will be a ptosis, like a drooping of eyelid would be seen. There would be a blurred vision, and snarling can also be seen in the eyes. Okay, so this is the major symptom will be seen through the effect into the smaller muscles. And if there is a bulbar muscle get affected or weakness is present, then we can see the slurred speech can be seen, and person cannot chew or cannot swallow. That's due to the muscle weakness. And if there is a proximal muscle weakness, then you cannot rise from the chair. You will be sitting. If you are sitting in the chair, then you will be keep sitting as such, so you cannot rise, and there will be difficulty in climbing the stairs, and also you even cannot brush your hair. At last the death will occur. That's due to the respiratory muscle weakness. The diaphragm, the major muscle for the respiratory, will get weakened, and the patient will die. But this is the surface level muscles or the major muscles, but the deep tendons and reflexes will not be affected in this myasthenia gravis, but can be seen in GB syndrome and Lambert Eaton syndrome. In these condition, you can see the condition affecting the deep tendons and reflexes too, but in myasthenia gravis, it is not be seen. How the diagnosis can be done? It is through the acetylcholine receptor antibody test, where 80 to 90% of the patient will have this antibodies, and anti-musk antibodies will be the patient will be having around 10% of the patient will be having this anti-musk antibodies when you do the diagnosis. And electromyelography you can hear done to confirm the myasthenia gravis. And chest CT can be taken just to see the thymoma, that's a tumor, or if the thymus gland is enlarged, that can be seen through the CT scan. And diagnosis also can be done by the Tensilon test, or also called as edrophonium test. Here, uh, you give the edrophonium to the patient who have the symptom. It will inhibit the antibodies which are blocking the postsynaptic receptor. So this edrophonium will block the antibodies from connecting to the synaptic receptor, and the symptom improves. All the symptom will reduce in within 5 minutes. That can be confirmed that the patient is having the myasthenia gravis. That is through the Tensilon test. One more test is Simpson test. Here, ask the patient to look up for 1 minute without lifting his head. So, without lifting his head, you look up like this Simpson seen in the picture. And if the eyelid has a fatigue, the eyelid will be drooped and ptosis can be seen. So, what you should do, you give the edrophonium 2 mg. That will improve the symptoms within 30 seconds, and if not improved, then 8 mg edrophonium can be given. There will be improvement within 5 minutes. That is the Simpson test. You can also do the ice test. The ice usually decrease the activity of acetylcholine esterase, and it will be application can be done on the eyes, and ptosis will be improved. Okay, and this is the ice test. And if we see the cholinergic crisis, so what is cholinergic crisis? Due to increased drug used in over aggressive treatment, acetylcholine concentration increases in neuroreceptor junction, and postsynaptic neuroreceptor gets desensitized. So what happens in the cholinergic crisis? Due to the aggressive treatment, in place of 8 mg, you give more dosage of edrophonium. So what happens here is the acetylcholine concentration will increase in this region of, or the postsynaptic region, and the neuroreceptor will get desensitized. It will not going to work for the increased concentration of the acetylcholine, so it doesn't work. So what is the treatment of myasthenia gravis? You avoid the drugs that exacerbate the myasthenia gravis. All the drugs which increase the symptoms of myasthenia gravis, you should avoid, like aminoglycosides, neuromuscular blocking agents in anesthesia or intubation, and magnesium sulfate, penicillamine, and fluoroquinolones also should be avoided. What is the therapeutic approach? Here you give the symptomatic treatment like acetylcholine storage inhibitor, example pyridostigmine. For the adult, you give 30 mg thrice a day with meal. So if patient feels excess cholinergic effect, you add glycopyrrolate 1 mg with each pyridostigmine dose. So with each pyridostigmine dose, you add 1 mg glycopyrrolate if the patient is having the cholinergic effect. And if not controlled here, then you should definitely go for the immunotherapy. Second treatment is chronic immunotherapy. Here you give the glucocorticoid, and if it is not controlled, add non-steroidal immunotherapeutic agents like azathioprine or mycophenolate. This can be used. It is a spare long-term glucocorticoid. Okay, that is the chronic immunotherapy. The third one would be rapid short-acting treatment where plasma exchange can be done. Also, one more is IV immunoglobulin can also be given. So it is done in the case of serious conditions like respiratory failure. As I told before, if the condition increases in the fourth or fifth stage, where the diaphragm gets weakened, there will be no respiratory process. So what you give is plasma exchange can be done, and IV immunoglobulin also can be given. And if you see in the CT that there is a tumor on thymus gland or enlargement of thymus gland, thymoma is present, then you go for surgical treatment is thymectomy. What are the indication? The thymoma, as I told, it was diagnosed in the CT or MRI, or if the patient is less than or 50 year and patient has general myasthenia gravis all over the body and acetylcholine receptor antibodies are present, then again you can go for surgical treatment. That is about the myasthenia gravis. Now we'll see one more differential diagnosis seen as myasthenia gravis, that is Lambert Eaton syndrome. Here antibodies are produced against the presynaptic calcium channel there in myasthenia gravis. Postsynaptic neuromuscular receptor, that is neurotransmitter receptor for the acetylcholine, but here it is for the calcium channel, but and also presynaptic antibodies are produced. Here calcium helps to release neuroreceptor vesicles from presynaptic neurons in neuroreceptor junction. Okay, calcium will help the presynaptic neurons in the uh, for the release of neuroreceptor vesicles in neuroreceptor junction. So if it is blocked by antibody, neuroreceptor vesicles will not be released to postsynaptic neurons. So from the presynaptic, the calcium will not be released through the to the postsynaptic neurons. So what happens will be repetitive movement, and it you there will be improvement in the condition and better with the days or time passes by. So in the clinical condition we can see that it is always associated with a small cell carcinoma of lung, and deep tendon reflex will be reduced. Autonomic features are part of this, like erectile dysfunction and incontinence also be present along with this disease. Okay, that's what about the two diseases in the neurology. We'll see you next time. Thank you.